Greetings. My name is Rohan Kulkarni, and I lead the Healthcare and Life Sciences practice at HFS Research. Welcome to HFS Unfiltered Stories Videocast. My guests this afternoon are Gloria Lau and Dr. J of Alpha Medical. Gloria Lau is the co-founder and CEO of Alpha Medical, whose mission is to improve access to women's health needs. In addition to running Alpha Medical, she's a consulting faculty at Stanford Engineering and also an alumni there with an MS and PhD. Mary Jacobson, MD, also known as Dr. J. Foundley, is the Chief Medical Officer at Alpha. She's an accomplished academic, board-certified obstetrician and a gynecologist, and a minimally invasive surgeon with extensive experience in clinical care, medical education, operations research, and hospital operations and research, and much more. I plan to discuss women's health today, and a particular reason to having Gloria and Dr. J on is that Alpha's mission, which aims to empower women to take control of their personal healthcare by providing patients with access to simple, everyday medical needs in a convenient, affordable, and discreet online process, powerfully resonated with me. So let me ask you, Dr. J, if you can help me level set the conversation for today about women's health in primary care setting and the impacts of it, please.
Sure. Primary care providers are the bedrock for preventative care and as first-line treatment for many routine health conditions. Primary care providers in the United States aren't necessarily placed where people are. They're concentrated in cities and in larger towns, and we have primary care deserts. And we want to bridge those deserts by providing primary care. We also notice gender inequity in healthcare, specifically bias against females assigned at birth. And we saw a gap in treatment, Rohan, for preventive health and women's reproductive health needs. We also wanted to address implicit biases and stigma that patients may feel in the office. And again, focus on gaps that we see in training of primary care providers with an understanding and being experts actually in women's reproductive health.
Thank you. That's really helpful. So let's talk unfiltered. Now at HFS Research, we recently published a market scan of digital health-enabled primary care providers in virtual settings. One of the movements we see is a focus on specialization, be it mental health, substance abuse, urgent care, and women's health. So 2 questions for you ladies. Do you recognize such a movement? And if so, what do you think is driving specialization in primary care, especially given primary care has typically been about broad family medicine?
Yeah, so Rohan, that's a great observation. You definitely see this pendulum swing every decade or so from full verticalization to full integration, right? So here's one of those moments. And you see it in the market, especially in consumer healthcare, where you have companies who verticalize into maybe just mental health or just birth control or just weight loss. So that's what we're seeing in the market. Now, I think there are many ways you can skin a cat, right? Like there are lots of ways to treat and help patients to create access that traditionally is difficult to obtain for healthcare. For us, our mission is always primary care, virtual primary care for women. That's what we do. And in our mind, to practice true primary care, it does mean that you have to be very broad spectrum. Officially on our site, we listed about 100 conditions or so. Unofficially, it really is anything under the sun that we can treat virtually for the patients, right? So think about more complicated conditions like heavy bleeding, endometriosis, migraine, so that whole broad spectrum. That's how we think primary care should be, and that's what we build as a virtual primary care platform for women.
Thinking about from the medical student's perspective, Rohan, I would say the role of primary care has gotten more complex. In the United States, specialists basically get paid a lot more than primary care providers, even though I would argue that primary care providers have a more difficult job. We focus on women's health because we noticed, again, an accessibility gap that needed to be addressed. And what do I mean by women's health? It goes much beyond birth control, as an example. It goes much beyond uterus, ovaries as organ treatment, which that's how we're trained in medicine, right, by organ system. So we try to focus on the whole person, which means the person's lifestyle, health conditions, diet, where they are in their reproductive life to contribute to their overall healthcare journey.
Understood.
I
Yeah.
think there's a lot to be said around the patient journey expectation of primary care too. Like we really want to reestablish that provider-patient relationship. And I think having that trusted relationship is really important. That means that it's the same provider you see time and time again. That is our model, right? Like every time you log on, you see Dr. J, and Dr. J gets to know you, and you get to know her style as well. That's very important. And by treating the whole person, right, it means that both mind and body, physical and mental health, it is handled by your primary care provider. Only if your primary care provider cannot efficiently treat you, then we refer you out, then it goes into specialty. That is what primary care should do, and that's what we're enabling on our platform.
Indeed, indeed. And just along those lines, Gloria, you've been delivering women's healthcare now close to 4 years here at Alpha. While I know your personal experience inspired you to launch Alpha Medical, the journey, I suspect, has taught you a lot about the genuine need for your services, given the limitation to access, clinicians not being adequately trained in medical school to treat women, for instance, or even the fact that women don't actively seek help as they put their family needs, ahead of themselves. So, if you don't mind, just share a couple of, profound lessons that you've learned along the way.
Yeah, so I started a company for a personal health reason. I was I have a women's health issue and was bounced around in the system between primary care, OBGYN, and a couple of specialties, right? And that is a very common story because when you go to a primary care provider, traditionally, oftentimes when you bring up anything that sounds reproductive in nature, say heavy bleeding, right? Like you get referred out right away to OBGYN. And OBGYN, like Dr. J mentioned, it's more around organs, right? Uterus and ovaries. Yet I want, as most patients want, a holistic view into your care journey. So that's one thing that we see time and time again with our patients. One of the most profound learnings that I've seen since running the business, right, is that the barrier to technology is actually pretty high, right? When you think about having a video conference like this, that requires sustainable Wi-Fi network. This is not something that we can assume of every patient. So our model is fully asynchronous, meaning it's like messaging a physician. You can do half of the medical intake form at home when you have reliable Wi-Fi, and the other half maybe after a bus ride to work when you have Wi-Fi again. So you're in control of your pacing as the patient, right? You're in control of when you want to be seen, quote unquote. And that's really profound because think about a woman maybe having to raise a child. The only time you have it could be at night after the child's in bed, right? So you do the medical intake form, but the child could wake up and seek your attention. So you have to break up these sessions, right? And that's historically very, very difficult if you were going to go into an in-person primary care provider, or if you were going to go into a phone call or a scheduled appointment of any sort. So that's one thing that we've learned, this modality of treatment. It's really working and inclusive, I would say, for patients in different areas of the country.
And Gloria,
Dr. J.
if I might just call out the fact that the virtual care that Alpha provides, it does not require for your patients to be on video, right? This is kind of everything is on chat, if I'm not mistaken.
Correct.
Okay.
And that's what allows it to be very, very accessible.
Indeed, indeed.
Some profound and nuanced effects I've seen about this asynchronous are basically communication and writing between providers in place and patients is that it reduces implicit bias, which is in the office in a brick and mortar setting, as well as stigma. And this is feedback we get from our patients. Our patients maybe with anxiety, who have too much anxiety to make a brick and mortar appointment, or even to have a televideo visit. They feel more comfortable in writing. Patients share with us about being dismissed or gaslit in different settings, let's say with respect to menopause symptoms or weight. Also on our platform, We know that unfortunately, the majority of primary care providers in the United States consider weight issues a lifestyle choice rather than a chronic medical condition, which we treat. So I think like that type of relationship with the patient is profound. And yes, we do build it via written communication. A few patient stories I want to talk about too. We had one patient who was undergoing in vitro fertilization in Spain, and she was back in the United States, and we were prescribing hormonal therapy for her in conversation with her physician in Spain. And she messaged back that she's 18 weeks pregnant, everything's going well, and thanked us for our services. Patients who see us for weight, a few patients thank us because with their weight loss, they're now able to play with their children, feel more comfortable going to social events. Patients with polycystic ovarian syndrome, we know that it takes about 7 years for patients to get diagnosed with this complex medical condition. And so they're really grateful about our education and the resources that we provide.
It is pretty powerful. I am struck by your comment about the implicit bias, not something I would imagine in a medical situation or a medical setting, but clearly, based on your comments, it is something that needs to be addressed.
Yeah, I agree, Rohan. And one way that we do it via telemedicine is that we ask the same questions to the patient. So in the office, you can imagine, when the clinician's busy and running an hour behind, they may take shortcuts and not ask all those key questions. They may not screen a person for depression, even though that person is due for that because of a lack of time. So it's shortcuts like that happen in in-person setting that we don't have that problem. And like Gloria said, patients can complete the medical intake form over more than one sitting. They're not pressured in a certain time frame.
Indeed. Let me shift topics on you for a moment here. I have written recently about what I believe is the likely disastrous impacts of the Supreme Court's decision to overturn Roe versus Wade. I believe it will have poor financial outcomes as women may be forced to quit workforce and schools. Health outcomes will likely get impacted or get worse due to the limitation on access to care and consequences of raising unplanned children and their health, as well as mental health issues arising from the trauma of being forced into a life-changing event. So the question for you is, what are you seeing on the ground, and how are you dealing with the consequences as they're likely going to be in different states?
At Alpha, we support the position of the American College of OBGYN, which affirms the legal right of a person to obtain an abortion prior to fetal viability. We also know that childbirth has approximately a 14 times higher rate of mortality or death than the risk associated with abortion. About 60% of women who obtain abortions in the United States are mothers. 24% of US women have had an abortion by 45 years of age. And over 61% of people in the United States believe that people should be able to obtain abortions during the first trimester of pregnancy. So I think there's a difference between our population in the United States and how it's being governed, and also how the courts are seeing abortion. Gloria?
Thank you, Dr. J. So to table set, right? Like we think reproductive care is healthcare. This is part of healthcare, and that's what we do, right, as your primary care provider. And that includes abortion when legal. So given the complex nature of Roe v. Wade and given all of the sort of shifting sand of regulatory environment in all 50 states, right? Like we're working closely with our general counsel and also external counsels on what we can do for patients. But fundamentally, we believe this is part of reproductive care, and that's part of your healthcare.
Are you seeing anything different on the ground in terms of patient care or the kind of conditions on the ground with some of your patients?
So, within the telemedicine industry as a whole, definitely the rate of medication abortion has increased. People with the means to travel to states where abortion is legal are doing that, and they may even travel to a state in order to get medication abortion via telemedicine. And we do predict, unfortunately, like I mentioned, that maternal mortality will increase over time, and we haven't seen that yet. Number three, in terms of medical school education, we predict that almost 50% of OBGYN residents will not be trained in abortion because of where their medical training is in the United States. And so the question is, how is that going to impact medical students as well as resident choices in where they decide to continue their training?
Indeed. I think, look, the data and the science is clear. I continue to be surprised at sort of the decisions that we make at a national level. Hopefully, we'll get that sorted out over time. Let's look into the future on that note. Social determinants of health, in my view, are critical to improving the triple aim of care, which is reducing the cost of care, improving health outcomes, and enhancing the experience of care. I think it is more so when it comes to women's health, given their propensity to put family first. What is your take on the use of SDOH, and how do you see it manifest in the real world? And if you have any examples you can share, that'll be brilliant.
Well, social contracts clearly have health impacts. We believe in meeting the patients where they are. And obviously, it's an individual patient. No group is a monolith, and it's important to recognize that, especially in healthcare. Our goal is to make healthcare accessible to everyone, regardless of their situation. We see asynchronous care or telemedicine care in writing is useful not only for a mom with 3 young kids, but also for a young professional woman busy in her career. In general, I think in the United States, where health plans struggle is navigating patients to resources. So let's say we review the social determinants of health with the patient in Duluth, Georgia, and cover that the patient has food insecurities. Well, we have to solve for that. We've got to know what the resources are in the local community in order to provide that for the patient. And so that is a bit of a conundrum right now in the United States is, some health plans are even wondering, do we even ask questions about social determinants of health and screen patients for that if we don't have a solution for their needs? So I advocate that, yes, it's important. And at Alpha, we're working on that in order to, bridge that gap if the patient does have, for example, food insecurities.
Excellent. Gloria, any other comments?
Yeah, so on SDOH specifically, I think it is very true to our mission, right? Where we provide affordable, accessible healthcare. And I think a lot of what Dr. J talked about, like if you really put it into a single patient story, right? You can think about like not having access to a car to drive to a brick and mortar clinician, right? That's part of SDOH. So with asynchronous telemedicine, we solved for that, right? Or even needing a discrete space, let's say a single mother in that same example, right? I need a discrete space to talk to the physician about something like heavy bleeding or painful period. Not everybody have access to that kind of environment, let alone the time. So by providing asynchronous telemedicine, right, by providing this care through messaging, you remove all of those traditional biases and barrier to the system. And that's why we're so bullish about this.
Excellent. This is fantastic. I just appreciate the fact that you are bringing technology, you're bringing empathy to primary care, and the fact that women's health in general in the country has been ignored to a great extent. I'm glad that you're kind of addressing the intersection of all of those three. So I really appreciate your time this morning. Thank you very much.
Thank you for having us.